Likewise, any other session that I have taken previously also, we would be focusing basically upon your ability to solve the MCQs related to the particular topic so that you are able to solve the MCQs for your forthcoming examinations as well as any other examinations you plan to give for pre-PG entrance. So let us begin with the structure, morphology, and functions of the dentine pulp complex. If we talk about the dental pulp and its origin, pre-PG entrance. Okay. The origin of the dental pulp is from the cephalic neural crest. Okay. I am talking about the embryological origin of dental pulp. It is from the cephalic part of the neural crest. And this cephalic part of the neural crest is made up of two mesenchymal cells. So both ectodermal and mesodermal cells, they take part and form the dentine pulp complex. These ectomesenchymal cells of the cephalic neural crest, they would form the dental papilla, and this would result into formation of dental pulp. This is the embryological origin of dental pulp from the cephalic neural crest cells. Now we talk about the structural organization of pulp. These are the fundamentals, or we can say the basics of the dental pulp, which are of particular importance for your NEET pre-PG examinations. Structural organization of the pulp. It is basically divided into 4 zones. When we study the histomorphology of dental pulp, 4 zones can be identified, and we would seeing it from outside to inside. Okay. The first zone, that is the outermost zone. Outermost zone is the odontoblast layer. The outermost zone of the dental pulp is the odontoblast layer. There is a single cell thick layer from the crown to the root portion of the dental pulp. There is a single cell thick layer that outlines the pulp. It is outlining the pulp means it is the outermost zone of the dental pulp, a single cell layer thick from the crown to the root portion of the pulp. Okay. So if this is a tooth, then this is the pulp organ of the tooth, just to illustrate schematically. Then this pulp organ in the outermost layer is outlined by a single layer of cells called the odontoblast layer. Single layer of cells. And how do we identify it? We see this layer under microscope. It is a histological appearance. But when we see this layer of the dental pulp, that is the odontoblast layer under the microscope, it appears 3 to 5 cell layer thick. In actuality, what is there? This is the real picture, that this is a single layer of cells that outlines the pulp from the crown to the root. But when we see it under the microscope, it appears 3 to 5 cell layer thick. And this microscopic appearance is called pseudo-stratified appearance. Pseudo-stratified. Pseudo means false. So falsely it is divided into 3 or 5 strata under the microscope. This is also called palisaded appearance of the odontoblast layer. Palisaded, divided into layers, a laminated appearance. But you have to remember that it is actually a single layer of cells that outlines the pulp. What could be the reason for this? The possible reason is that the nucleus of adjacent odontoblast are at different vertical levels. They are at different vertical levels, the nuclei. So if we talk about the odontoblasts like these, which outline the pulp, the nuclei are not at the same level, but at the different level. And because of this, it appears pseudostratified in appearance under the microscope. These odontoblast layers, cells, in the crown portion of the pulp, or we can say in the coronal pulp, they are tall and columnar cells. Tall and columnar cells. In the midroot area of the pulp, they are cuboidal cells. And in the apical root, in the apical portion of the dental pulp, they are flat, squamous in shape. So the pulp from the crown to the root throughout is outlined by a single layer of cells that appears pseudo-stratified under the microscope. The reason I have told you already. And when we talk about the shape of these odontoblast cells, it changes from tall columnar in the crown to the flat squamous in the apical portion of the dental pulp. If we talk about the function, these odontoblasts, they have the principal function of secreting dentine. They are the principal secretory cells that produce the dentine. So this production of dentine is the primary function of odontoblast layer. They also produce some type of collagen, which forms the organic component of the dentine, principally type 1 collagen with traces of type 5 collagen. Principally, they would produce type 1 collagen. Only type 5 collagen is produced in traces, subtle amounts. If we talk about cell to cell connections, cell to cell connections between odontoblasts, then principally three type of cell to cell connections exist between the odontoblast. What are they? They are the gap junctions. Okay. We are talking about the outermost layer of the dental pulp, that is the odontoblast layer. Gap junctions, tight junctions, and desmosomes. These are the three type of connections that exist between the adjacent odontoblast cells. These gap junctions, they are made of protein called connexin. They are made up of protein called connexins. And the tight junctions, they regulate permeability of odontoblast layer. So the permeability is regulated by the tight junctions and not the gap junctions. Important thing to note. So all these are frequently asked questions related to the odontoblast layer. Then the second layer from outside to inside, it is the cell-free zone. The subodontoblastic zone of the dental pulp is called the cell-free zone, which is also called cell-free zone of Weil or Weil's cell-free zone. As the name indicates, cell-free zone, it does not contain any cells. But what does it contain? It contains mostly unmyelinated nerve fibers that form a subodontoblastic plexus. They consist of capillaries for the blood supply, and they consist of dendritic cells. Okay. some, dendritic processes of cells. No cellular components are present, dendritic processes of cells are present. This is basically a 40 micron wide zone, which is present below the odontoblast layer, subodontoblastic cell-free zone. The third layer of the pulp from outside to inside is the cell-rich zone. The cell-rich zone is also called zone of Hall, HOHL. And as the name indicates, cell-rich zone, it consists of numerous cells. What cells are present? The principal cells which are present are fibroblasts. They are the stellate cells with projections. We would say star-like cells are present, fibroblasts. They are the most abundant pulpal cells. They are the most abundant pulpal cells, fibroblast. And as the name indicates, fibroblast, they secrete collagen. What type of collagen is produced by fibroblast? It is type 1 and type 3 collagen that is produced by fibroblasts. Then other cellular components of the pulp which are present in the cell-rich zone are undifferentiated mesenchymal stem cells. UDMSC stands for undifferentiated mesenchymal stem cells. These are multipotent cells. If we talk about the potency of stem cells, the totipotent cells, they are the most potent cells. Means a single cell can give rise to an entire organism, including the specialized membranes like placenta, etc. Then next in the differentiation potential, they are the pluripotent cells. Means they can form almost all cells of the body, but they do not form the specialized membranes like placenta. Then lesser differentiating cells are multipotent cells, which are present in the dental pulp. These multipotent cells can give rise to a specific type of cells. They cannot form all type of cells. So what cells are present in the dental pulp? They are the undifferentiated mesenchymal multipotent stem cells. They are mostly present in perivascular areas of the pulp because they require a rich supply of nutrients, they're mostly present in the perivascular areas. Then other cell types are macrophages. These macrophages which are present in the dental pulp, they are derived from blood monocytes. Monocytes of the blood. These macrophages, they have got two functions. One is the primary function of, if I talk about the functions of macrophages, and another is the secondary or the minor function. Primary function, as the name indicates, macrophages, they phagocytose. Phagocytosis of antigenic materials like bacteria, viruses, etc., which present a challenge to the pulp during disease. Secondary function is they act like immune cells. Okay, they contribute to certain immunity of the dental pulp by recognizing certain antigens. But the primary function is phagocytosis of antigenic material. Then another cell types present in the pulp are the dendritic cells. Dendritic cells. These dendritic cells are also called APC or antigen presenting cells. Antigen presenting cells or APC. These dendritic cells, They are principally immune cells. They are the primarily immune cells of the dental pulp. They recognize antigen. So whenever there is some infection or invasion of the dental pulp by certain bacteria, viruses, or other microorganisms, they would be recognized by the antigen presenting cells that present it to the immune system of the dental pulp. So in a normal pulp, or we talk about a healthy pulp, these dendritic cells are present in the periphery. Obviously, to be able to recognize the antigens, because whatever external invading organisms are present would be invading the pulp from the periphery. So in a normal pulp, they are present in the periphery. And when the pulp becomes inflamed, they migrate to the center along with the antigen. Then another cells are lymphocytes. I am talking about the cellular structures present in the dental pulp. Fibroblasts, they are the most abundant cells, followed by mesenchymal stem cells. Lymphocytes, from the basics of the knowledge of lymphocytes, we know that there are two types of lymphocytes, B and T lymphocytes. Okay. Incidence of B lymphocytes is not based upon evidence. So the dental pulp would contain very less amount of, or not at all, any amount of B lymphocytes. But there are significant amounts of T lymphocytes present, which are contributing to cellular immunity. So they contribute to cellular immunity. And the major T lymphocytes present are majorly they are T8 suppressor cells. T8 suppressor lymphocytes. Numerous subtypes of T lymphocytes are present, each having a specific function. The dental pulp contains most abundantly the T8 type of suppressor T cells. Then there are certain cellular organisms like mast cells. Okay, these mast cells, they are not present in normal pulp, but they are part of inflamed pulp. So whenever there is inflammation, the circulating blood cells and the epithelial cells, they would give rise to the mast cells. These mast cells, they have characteristic granules present in them. So whenever there is pulpal inflammation, these granules would be released from the mast cells that release histamine and heparin. When? When there is inflammation of the pulp. Histamine is a vasodilator, an inflammatory mediator that is a vasodilator, and heparin is anticoagulant. So both of them give rise to characteristic appearance of copiously bleeding pulp, which is clinically indicating that it is a inflamed pulp. So whenever the pulp is copiously bleeding, it would be having mast cells that liberate granules like histamine and heparin that increase the profuse bleeding of the dental pulp. So that gives rise to the copiously bleeding inflamed pulp. These are the different types of cells which are present in the dental pulp. I am not saying that all these cells are concentrated in the cell-rich zone. They would be present in the other layers also, but the maximum amount of these cells are present where? In the cell-rich zone. And the fourth zone from outside to inside of the dental pulp, it is the pulp proper. So basically, what type of connective tissue is pulp? Pulp is a loose connective tissue. So if we have to classify dental pulp as what type of tissue it is, then we would say it is a loose connective tissue. Pulp proper consists of large blood vessels, and nerve fibers, and different cells. What are the different cells? We have already seen with the cell-rich zone. So from outside to inside, this is the basic structural organization of dental pulp, from the odontoblast layer to the cell-free zone to the cell-rich zone and to the pulp proper. Now we talk about innervation of dental pulp. We all know that innervation of the dental pulp would be basically from the trigeminal nerve, which is the fifth cranial nerve, isn't it? And it is a, what type of nerve is mixed? Trigeminal nerve, it is a mixed nerve. It consists of both motor and sensory fibers. So it is derived from the trigeminal nerve. Firstly, we'll talk about the sensory supply. The sensory nerve supply of the pulp consists of two types of fibers. They are the A fibers and the C fibers. Different categories of sensory nerve fibers are there: A, B, C, etc. So the pulp sensory supply consists of A fibers and C. A fibers are the myelinated fibers. C fibers are non-myelinated. And we have to look at the amount of these fibers. Then 20% of the sensory nerve fibers are A fibers, and majority of the sensory nerve fibers in the dental pulp are C fibers, non-myelinated fibers. These A fibers which are present in the dental pulp are further of two subtypes: A beta fibers and A delta fibers. A beta fiber constitute only 10% of the A fibers, and A delta fibers, they amount to 90% of the A delta fibers, A fibers. So we are talking about the sensory innervation. So what type of sensations are carried by the A beta fibers? That is pressure sensation. They are the proprioceptors. They sense pressure. A delta fibers, they sense pain, principally temperature and touch. Principal sensation of A delta fibers is pain. They also sense temperature and touch. So when we talk about the pain, what is the quality of pain that is produced by the stimulation of A delta fibers? A sharp, short pain. Sudden electric shock like pain. Sudden, when we bite upon very cold ice cream, we feel pain. A sudden pain for a couple of seconds is there. That pain is stimulated by A delta nerve fibers. So as the name indicates, A delta nerve fibers, they are the principal type of myelinated nerve fibers, and they are present in periphery of the pulp. If we come over to the C fibers, which are the major type of sensory nerve fibers, they are mostly present in the center of the pulp, and they carry the sensation of only pain. Okay. So the major fibers responsible for the deep-seated pulpal pain would be the C fibers. That's why they are present in 80% concentration. They are also called principal nociceptors. What are nociceptors? Fibers which carry the sensation of pain. So these pain-carrying fibers of the pulp, they are the C fibers, and they are called principal nociceptors. Okay. They are stimulated by these principal nociceptors. They are stimulated by temperature, greater than 110 degrees Fahrenheit, acidic pH less than 6, and certain chemicals like capsaicin. Capsaicin is basically a chili extract that has the potential to stimulate the C fibers. Chili peppers it consists of. Okay. These various methods of stimulation of C fibers are present, and because these C fibers are the principal nociceptors and they can be stimulated by different mechanisms like temperature, pH, chemicals, they are also called polymodal nociceptors. What are nociceptors? Fibers that carry the sensation of pain, and polymodal means there are different modes for the stimulation of these C fibers. And as they are the nociceptors, dull throbbing pain is carried by them. They cause what type of pain? Dull and throbbing pain, which is in contrast to the A delta fibers, which form a short, sharp pain. This dull throbbing pain caused by the C fibers is less bearable as compared to the pain carried by the A delta fibers. So whenever there is extensive tissue damage due to a deep-seated carious lesion or a trauma, then major amounts of C fibers would be stimulated and they would cause dull throbbing pain. Okay. This is a sensory innervation of the dental pulp. Then we have postganglionic sympathetic nerve fibers. The second component of the innervation consists of postganglionic sympathetic nerve fibers, which are derived from superior cervical ganglia. Superior cervical ganglia. Okay, so what are the two components of the innervation of the dental pulp? It would consist of an afferent or the sensory component consisting of the A and the C type of fibers, and it consists of efferent component. Efferent component is postganglionic sympathetic nerve fibers that have the function of neuromodulation. Definitely, there would be no motor function in the dental pulp. There would be a sensory and a postganglionic sympathetic part, which causes neuromodulation. It regulates the functions of the dental pulp during health and during inflammation. So these are the two components of the innervation of dental pulp. Now, clinically, whenever we do root canal treatment for an pulp that has been irreversibly inflamed, we take out all the nerve fibers, whether they are the sensory or the postganglionic efferent fibers, isn't it? In certain cases, in 3 to 6% cases, there is persistent pain. Persistent pain after RCT. Persistent pain means the pain continues for more than 6 months after doing root canal therapy. It has an incidence of 3 to 6% cases, and this persistent pain, which is present in a well-treated tooth with non-surgical root canal treatment, is called phantom tooth pain. Phantom tooth pain means, ideally speaking, there should be no pain because we have removed all the sensory and other fibers from the dental pulp. But still the patient complains that there is no other cause for the root canal looks adequate in all aspects. There are no missed canals. The cleaning and shaping is adequate. The obturation is adequate, but still there is pain to a patient, and that is persistent in quality. Persistent means continues for up to 6 months after root canal treatment. This phenomena is called phantom tooth pain, and it has an incidence of 3 to 6%. Sometimes we technically also called it deafferentation. Deafferentation. Another term that is used is deafferentation pain. Why deafferentation pain? Because we have removed all the sensory nerve fibers. That is called deafferentation. There is a molecular reason for this. Especially in cases of chronic pulpitis, there is upregulation of secretion of C-FOS gene factor on the nerve fibers. In cases of chronic pulpitis, there is a molecular upregulation of these nerve fibers that gives rise to the phenomena of phantom tooth pain. Okay. Now we talk about pulpal circulation or the blood supply of the dental pulp. See, pulpal blood supply would be majorly from the maxillary artery. And maxillary artery, all of you must be knowing that it is a branch of external carotid artery. It is a branch of external carotid artery. Pulpal blood flow. This pulpal circulation is very high as compared to other parts of the body, and the blood flow makes up 3% wet pulp weight. Means if we talk about a healthy pulp that is not inflamed, then blood circulation is very copious in it. It makes up about 3% of the weight of the dental pulp. Okay. If we talk about resting rate of blood flow, then this resting rate of blood flow is in the range of 15 to 60 ml per minute per 100 gram tissue. Very high as compared to other body tissues. That's why the pulp is very richly vascular. 15 to 60 ml per minute per 100 gram. Remember that the figure I have given is for 100 gram of the tissue. If it is asking about the per gram of the tissue, you divide the figures by 100. Okay. This blood flow is more in peripheral pulp and less in central pulp. If we talk about the blood flow, it is higher in the peripheral pulp. Maximum is present in the areas of the pulp horn, less in the central pulp. And we all know that blood consists of hemoglobin that carries the oxygen to supply the required nourishment to the tissues. So, rate of oxygen consumption of the dental pulp is in the range of 3.2 plus minus 0.2 ml per minute, again per 100 gram of the pulpal tissue. I am again stressing that whatever figures I have given is for the, whether it is for the rate of blood flow or rate of oxygen consumption, it is for 100 gram of the tissue. 3.2 plus minus 0.2 ml per minute per 100 gram of the tissue. This rate of oxygen consumption of the dental pulp is reduced by certain dental materials like zinc oxide eugenol, calcium hydroxide, and dental amalgam. These materials they reduce the rate of oxygen consumption of the dental pulp. Certain procedures like orthodontic force also reduces the rate of oxygen consumption of dental pulp. Thus, dental pulp has an average capillary density of nearly 1400 per square millimeters of the dental pulp. It is very richly vascular. Okay. And whenever there is flow of blood through the tissues, especially for a dental pulp, which is a soft tissue, in a special situation means this soft tissue is confined in the encasement of dentine and enamel on top of it. So it is present in a very low compliant environment. There can be no or very little change in the volume of the pulp. So normal pulp has a intrapulpal pressure that is represented in millimeters of mercury column, and the value is 10.2 millimeters of mercury, normal intrapulpal pressure. Sometimes we give this or measure this intrapulpal pressure in water column, then it would come to 14 centimeters of water column, either 10.2 millimeters of mercury or 14 centimeters of water column. Whenever there is inflammation of the pulp, I've already told you that it is a very low compliant environment. In pulpal inflammation, we know that there would be release of certain inflammatory mediators that cause two specific changes in the pulp. That is, one is vasodilation, isn't it? There would be mast cells that would release histamine and heparin. So there would be vasodilation in inflamed pulp, and there would be increased vascular permeability. These two phenomena happen whenever there is inflammation of the pulp or pulpitis. And because of these two phenomena, there would be increased amount of blood that increases the intrapulpal pressure. This would increase the intrapulpal pressure. And how much the pressure increases? It increases to nearly 3 times. That is in the range of 30 to 35 millimeters of mercury. So what is 10.2 millimeters of mercury? It is the pressure of a normal pulp. What is 30 to 35 millimeters of mercury? Pressure of a inflamed pulp. Average values. And more severe the inflammation, more severe will be the pulpal pressure. And you must have seen a common clinical observation that a person who is suffering from irreversible pulpitis, advanced stages especially, would be finding relief from dental pain due to cold stuff. Because of something cold like cold water or ice cream, instead of pain, there would be relief of pain because the pressure is already elevated. And when the patient eats or drinks something very cold, the pressure plummets and the patient finds relief from pain. So, if a patient is giving a history of relief of pain due to cold application, it can give you a diagnosis of advanced irreversible pulpitis, pulpal necrosis. Okay? That's why the pulpal pressure is important to understand. Okay. Interstitial fluid volume. We talk about the interstitial fluid volume. It is in the range of 3.6 plus minus zero point 0.3 ml per gram of tissue. 3.6 plus minus zero point 0.3 ml per gram of the tissue. This is for per gram of the tissue and not per 100 gram of the tissue. Okay. This is about the blood circulation of the dental pulp. Below the pulp, we then talk about certain age changes of dental pulp. One of the most frequent age change of dental pulp is formation of pulpal stones. or denticles are formed. These pulp stones, they have an incidence of nearly 50%. They're present in 50% of the cases. And the pulp stones can be categorized into two principal types. One pulp stones, they are round or ovoid with a smooth surface, and concentric laminations. So there would be multiple layers like this of pulp stone. They can be round or ovoid, but they would be having a smooth surface with concentric laminations. Okay. And they grow by apposition of collagen fibers on the surface. Means the collagen fibers keep on adding to it. We know that pulp consists of collagen, type 1 collagen principally present. Okay. So these collagen fibers keep on accumulating over the surface and they are being calcified over time. Another type are diffuse calcifications. Okay. Which have got no particular shape, and specifically they have got a rough surface as against that of concentric laminations that have got smooth surface. Okay. So they can be of any irregular shape. Okay. They grow by calcification of preformed collagen fibers. Means the lump of collagen fibers into various shapes is already present, which undergoes calcification. Okay. These pulpal stones, both the types, they are basically consisting of carbonated hydroxyapatite. HA stands for hydroxyapatite. If we talk about these two pulpal stones, then the incidence of these concentric laminated pulpal stones is not related to the age. They can occur at any age, whether the person is young or old. It has no particular age incidence. But the incidence of these irregular type of calcifications is age related, means the incidence of such calcifications increases up to 25 years of age. The incidence increases up to 25 years of age. After that, no clinical establishment has been related to the age, but definitely up to the 25 years of age, young adults, the incidence increases. Then, at times, in the radicular pulp, especially in the radicular pulp, another form of calcification occurs that are remnants of Hartwig's epithelial root sheath. Excuse me. Remnants of Hartwig's epithelial root sheath. They stimulate undifferentiated mesenchymal stem cells that give rise to odontoblast like cells. Okay. They form calcifications. So another type of calcification that is more prevalent in the radicular pulp is derived from odontoblast-like cells derived from the undifferentiated mesenchymal stem cells. Okay. What is the characteristic of these calcifications? They contain tubules because they form dentine-like tissue, so they would consisting of tubules microscopically. Okay. And sometimes there is calcific metamorphosis of the pulp. Calcific metamorphosis of the pulp in cases of luxation injuries. Whenever the pulp is subjected to certain luxation injuries, especially in cases of immature teeth, there is calcific metamorphosis of the pulp that give rise to yellowish discoloration of tooth. Okay. Only 7 to 10% cases it is permanent, and others it is a reversible phenomenon. So it is important to note that calcific metamorphosis, which happens in traumatized teeth, especially in cases of severe injuries like luxation injuries, it gives rise to mild yellowish discoloration of the tooth due to calcific metamorphosis of the tooth pulp. And this is, in majority of the cases, is a reversible procedure and does not require any treatment like root canal or any other endodontic intervention immediately. Okay. If in the long term it is not reversible, then only we need to do RCT for such cases, but which is very, very less, 7 to 10% of the cases only. Apart from these different types of calcifications, as the person ages, the cells decrease in number. The collagen fibers, on the other hand, they increase in number and size. Both the size and the number of fibers increases in a mature pulp. What? Collagen fibers. This we can talk about it. Now we talk about certain dentinal aspects related to the pulpal. We know that immediately above the pulp is the dentine. Dentine is also a very dynamic tissue that has a basic function of protecting the pulp from all sort of insults. So whenever there is a dentine coverage over the pulp, this dentine consists of dentinal tubules, okay, and 40% of the tubules in the crown portion, they consist of A delta fibers, and only 10% tubules in the root portion of dentine consist of A delta fibers. So although the A delta fibers are present in the periphery of the pulp, some of them cross the pulpal junction, enter into the dentinal tubules to about 100 to 400 microns into the dentine. And when we talk about the crown portion of the dentine, 40% of the tubules consist of A delta fibers. And this is the reason that whenever you take certain fluids or other stuff which result in dentinal tubular fluid movement, there is stimulation of A delta fibers and pulpal pain is perceived. Although no clinical exposure of the pulp is there, but still the stimulation of A delta fibers through the movement of the tubular fluid. And this is also one of the principles that we are able to use a cold testing method and electric pulp tester, because both of them would result in stimulation of A delta fibers by way of tubular fluid movement. Okay. Whenever there is carious insult of tooth, carious insults of the tooth, we would be talking about dentine. Then two type of stimulus can be there: mild to moderate intensity stimulus. Okay. And then there can be a severe stimulus. Whenever there is a mild to moderate intensity stimulus, it causes formation of reactionary dentine. Reactionary dentine is formed by the same odontoblasts. There is no damage to the odontoblast. The previously we know that the outermost layer of the dental pulp is the odontoblast layer. The same odontoblast layer would secrete a layer of dentine that is called reactionary dentine in response to a mild to moderate intensity stimulus. This reactionary dentine is characterized by a deposition of calcium salts in dentinal tubules. And mostly which type of calcium salts are deposited? They are the Whitlockite crystals. Calcium Whitlockite crystals. They are deposited inside the tubules and they reduce the dentinal permeability. And what type of dentine we call it clinically? This reactionary dentine is called sclerotic dentine. Whenever the intensity of stimulus is mild to moderate, it does not cause damage, but it starts forming, these odontoblasts start forming another layer from inside. On the other hand, whenever there is a severe stimulus, it causes death of odontoblasts. The odontoblasts, which are present in the periphery of the pulp, they become denatured. They die because of the severe stimulus. And what happens next? Whenever the stimulus is removed and a suitable pulp dressing is given with a material like MT or calcium hydroxide that stimulate the pulp, there is proliferation, migration, and differentiation of new odontoblasts. Because the old odontoblasts have already died, there would be proliferation, migration, and differentiation of new odontoblasts. These new odontoblasts, from where they would come, we all know that there are undifferentiated mesenchymal stem cells present in the pulp. From these undifferentiated mesenchymal stem cells, these new odontoblasts would come into picture. And they lay down a new layer of dentine that is called reparative dentine. Reparative dentine. The usual rate of deposition of reparative dentine is in the range of 3.5 microns per day. And these neuroendoblasts, they are formed from undifferentiated mesenchymal stem cells in about 15 to 30 days time. So, in other ways, how much time do we have to wait for the reparative dentine to be formed after initiation of a good material that is placed onto the pulp? It would be in the range of 30 days. So, there would be a delay of nearly 1 month till the formation of a reparative dentine starts after a severe stimulus is treated. This reparative dentine is less tubular, it is more tortuous. The tubules are more tortuous as compared to regular dentine. Right. These are some of the clinical changes that happen whenever there is a stimulus that is either causing damage to the odontoblast or causing a low grade stimulation of the odontoblast, which are the cells of the pulp. So, pulp and dentine are closely related to each other. Okay. If we talk about primary dentine, it is usually laid in the rate of 4 microns per day. Okay. Secondary dentine, which is also a physiological form of dentine, is laid out in the range of 0.6 to 2.8 microns per day. And reparative dentine is laid at the average rate of 3.5 microns per day. So you have to look for the specific clinical situations and then answer accordingly. These are the basics of the dental pulp and dentine histology and morphology related to the clinical aspects of the endodontics. With this, I am concluding my today's session. I hope you have been able to understand the structure and functions of the dental pulp dentine complex. With this, I am signing off and see you again in another session of YouTube MDS Quest. Till then, happy reading. Goodbye, everyone. Thank you so much for being connected with me.